Welcome to the Physical Medicine Provider Clinical Training Module on excessive frequency. This presentation today will be held by Andrew Dietz, our Senior Provider Relations Manager and Physical Therapist. Hello, everyone. My name is Tina Kaplan, and I'm the Vice President of Provider Relations for Magellan Healthcare. I've been with Magellan now for 13 years, and I oversee all of the provider relations and education for our providers. Now, a little bit about Andrew. Andrew is a board certified and licensed physical therapist. He has over 13 years of experience in clinical practice, clinical operations, and business administration. Much of Andrew's career was spent in the orthopedic and geriatric setting where he conducted private practice work. Now, in 2020, Andrew joined Magellan Healthcare as our Senior Provider Relations Manager and Physical Therapist. He is currently working on projects to improve physical medicine provider relations through our robust provider analytics and also working directly with our National Association relationships and provider education that he provides for his various health plans. Now, the purpose of today's clinical training is to inform and educate our clinical physical medicine providers on what information to support the medical necessity needs of these services. Now, we're going to go into the medical necessity of the physical medicine services, excessive frequency, moderate frequency. We'll also talk about excessive requests, and Andrew will go through our physical medicine tip sheet. He'll talk a little bit about our peer-to-peer documentation. And lastly, we'll go through our contact information and also information on RadMD, which is our web portal. So at this point, I'd like to turn the presentation over to Andrew.
Today, we'll first discuss medical necessity, understand what medical necessity is, and realize that medical necessity is the foundation of every episode of care for medically covered services. Medical necessity is guidance towards justification for those medically covered services, and it's also to establish the reduction of any denial or partial denial rates that are requested through both initial authorization requests and subsequent visit requests with our program. One of the top reasons authorizations are either denied or partially denied or subsequent visits are not approved is that there's a lack of supporting clinical information that is directly related to a patient's diagnosis, and also a lack of a reason for needing those therapies. Clear, concise, and objective information that is both supporting for medical necessity and the need for skilled care are those foundations of establishing appropriate clinical care and justifying medical necessity. Clear documentation should be provided to support the clinical and medical necessity of both the initial authorization process and any subsequent visit requests. Excessive frequencies is a component of justifying medical necessity. We'll transition now into excessive frequency, and we'll start with our intense frequencies. And those are generally your requested frequencies of 3 times a week or more. Generally, they're considered for your severe delays or severely impaired episodes of care. Or if you have a specialized treatment protocol, the intense frequency of 3 times a week or more is generally appropriate for those types of scenarios. The intense frequency, again, of 3 times a week or more may be or is usually appropriate during an initial phase or the acute phase of someone's episode, but it typically progresses and decreases in frequency throughout the timeline of that episode as a person is improving, reaching their goals, and is ready for discharge. The intense frequency of 3 times a week or more consistently will require additional documentation and testing to support, just like the documentation for skilled care and medical necessity is needed to justify services. We'll now transition to moderate frequency, and moderate frequency is more of your 2 times a week episodes of care, where this should be consistent with your moderate delays and should be established by objective measures and the general guidelines that are used for conducting formal assessments in the evaluation and any progress notes. Both of these examples of moderate and excessive moderate and intense frequencies, again, should be related directly to the individual's episode of care. And when you have an episode of care that is a low level impairment, person is highly functional, not much happening as far as comorbidities, and you request 3 times a week for weeks or months during an episode of care, it doesn't correlate well versus someone that is being requested 3 times a week for weeks or months that does have a lot of comorbidities, high levels of impairment, high level of disability. So when you are submitting for your requests, make sure your requests are in line with that person's comorbidities, functional delays, impairments. Another important component of excessive frequency is requesting excessive requests. This often leads to partial denials, and providers commonly will submit for excessive requests in trying to get a bunch of visits up front for an episode of care. And what this does is you have a plan of care that's submitted for those excessive visits, and it does not allow for any demonstration of progress throughout the episode of care towards any goals that have been established. It doesn't allow to look at any improved functions at any regular time frames. So for example, a provider might request 48 visits at 2 times a week. This would generate 24 weeks of treatment or 6 months. And during that entire 6 months, there's no regular review of progress or impairments during that time. So that excessive request will often lead to a partial denial. When you have visits that are approved and are used, the provider should submit current notes for review. These records will be reviewed for medical necessity and could or should include the progress note, most recent progress note, with any updated objective measures, the status of any functional goals, the plan of care with any updates to any frequency and duration, the reason for ongoing or continued skilled care, and also any relevant visit notes. There is a physical medicine tip sheet, and here at Magellan Healthcare, we do issue authorizations in accordance with Magellan's internal healthcare clinical guidelines and also the Milliman Care Guidelines for therapy. A link to these clinical guidelines can be found on www.radmd.com under Solutions, Physical Medicine. Magellan Healthcare Guidelines for therapy services are based on evidence-based research, generally accepted industry standards, and best practice guidelines established by the corresponding national organizations, such as the APTA and the AOTA. There is a peer-to-peer documentation process which allows for verbal clarification of any information that was present in the submitted documentation, if it was either uploaded to our RadMD system or faxed. These examples can include any clarification of that submitted documentation for any conflicting information or any typographical errors. During the peer-to-peer process, if there is any new information that is necessary to approve the request, that information must be either uploaded to RadMD or faxed, which is then reviewed by our clinical team before an approval is possible. Here's a helpful list of contact for you as providers of the initiating process for authorizations. If a provider does need to initiate or check the status of an authorization, they will visit www.radmd.com. The peer-to-peer consultation process that I discussed previously has a dedicated phone line to initiate that. Any technical issues related to RadMD, you can submit that request to the email or call the dedicated 1-800 number. And any provider education requests or specific questions to Magellan Healthcare, there is a dedicated website for that area as well. That concludes our training for today. I want to thank you for attending, and I hope you have a great day.